Well, welcome everybody. Dr. Lucchese, what a wonderful presentation. And
You
Dr.
really thought
Trindade.
so, Joel? You really thought so? You're not just saying that, are you?
No, I did. And I like the, Jill and Jane, um, good choice of names. And anyway, I actually did because I follow, that same algorithm. And I think it's very helpful. And I hope that our participants will look at that slide and even reproduce it to have with them. So thank you for that. We've got an incredible number of questions here, so we're going to get through as many as we can. So Dr. Trindade, there's a lot of questions on the herbals that you use for restoring adrenal function. And the list that you gave on your slides, different lists on different slides, there's a lot of them. So there's a lot of questions on how do you personalize, how do you decide what botanicals to give out of the choices of 3 or 4 in a particular category?
I usually go by the ones that are there's more literature information on it, and also what I'm trying to achieve and what's going on with the patient. And that was why I was trying to help you kind of decide that by looking at, are they stage 1, are they stage 2, are they stage 3? And also based on what they do and where they act. Some will act more on the HPA axis, others will act more directly on the cortex, adrenal cortex. But even within that, there's a lot of choices. And I would say do the ones that you feel more comfortable with. When I was first starting out, I just looked at as many research papers as I could and decided which ones am I going to use. Rhodiola, for example, has quite a bit of information on it. So does ashwagandha, whether it's on autoimmune conditions. It's now actually starting to be used oncologically with cancer patients because it's been used in lung cancer, ovarian cancer, breast. So I think that we each have a baseline, or we each have sort of our own foundation that where we are already doing or have already been doing. Just build on that and see what you feel comfortable with. I also like doing it based on some of the patient complaints. I may use L-theanine more on someone who's having racing thoughts or difficult going to sleep. So you can use what you already know and patient symptoms, and then everything that I covered has been reviewed in the literature, but some have more literature background than others. It really comes down to one step at a time. What do you already know and where do you want to go with your learning?
So what are your thoughts about the blends that different nutraceutical companies have out there for adrenal support? Do you feel that if you use that, you're not helping your patient, that you need to really personalize it? Or do you think it's okay to use some of those blends?
I think it depends on the nutraceutical and on the nutraceutical company and what they've done, because some nutraceutical companies have put everything in one formula. And usually the more things you have, the more possibility that someone can react to something, whether it's a sensitivity, an allergy, or just an intolerance. So some companies have actually taken the extra step and created formulas for hypercortisol states and others for hypo. And as long as it's a GCMP certified company, which means that was treated just as if they were manufacturing a drug, they follow the same purity, content, and adverse reaction. So in other words, if you have an adverse reaction, you need to call in, it needs to be documented. And then the product would be batch tested to make sure there wasn't a problem with the batch. So as long as it's a GCMP certified company, it's all about what you feel comfortable with. I prefer to use less combinations with patients, and some of the nutraceutical companies have a lot of them out there. And then usually what I do, and I did in the beginning especially, was I would research each ingredient if there was a product, for example, for a hypercortisol state, and then see how comfortable I felt using that particular product. It's a lot easier than using than using it singly, right? But there's some that are not necessarily very well research-based or very well documented in the literature.
So Joel, can I just add a couple thoughts to that? So I absolutely agree with Philomena with the two additional thoughts that when you start to combine all these things, I suppose you could, there could be some reactions as Philomena talked about, but also you generally don't get to at least the research levels of these particular botanicals. So they're combining 4 or 5 things, not at the levels that the research, but at partial levels with the idea that that they are somehow additive or synergistic. It's not a bad idea. That hasn't been studied. So you have to use your clinical experience. If Philomena is talking about she's using a particular formula that she feels she has good clinical experience with, I'm not going to argue with that. But I will say that if we're talking about ashwagandha at 600 milligrams twice a day and it has these effects based upon this study, that's not what's in that formula that has 5 or 6 different things. So I think we should all keep that in mind. The second thing that I think is important is having standardized extracts of these botanicals, because we want to have a marker compound. That doesn't mean that's the only thing in that botanical that's working, but if we're standardizing to something, that's going to give us a better understanding of batch to batch. And many of these companies that are in the virtual exhibit hall do have standardized. That's just what I use and what I support to have more consistency over different different products and different companies.
And I would agree, and I would say when I was first starting out back in the day, I relied on those blends, and I worked with companies that exhibited at IFM, and with research, and if it sounded good, I tried it, and through trial and error, you really do notice when you get good results and patients come back and they're like, wow, yeah, I feel more energized, or you know what, I really do feel less wired. So you do find out what works and doesn't work. So just a sort of extension to this question, what about adrenal glandulars that are part of these adrenal support formulas, or even in isolation? What are your thoughts about those?
So I tend to stay away from glandulars. There is literature regarding glandulars. It's more in the veterinarian literature and maybe some of the older literature. I know there's some people that use them. I've had some experience with it in the past, some good and some not so good. So in general, I pretty much follow what I talked about in terms of lifestyle modification, nutraceuticals, botanicals. I haven't started patients on glandular that much. If they come to me already on a glandular, I will keep them on that. But in general, I find that I could get good results without it. There have been a couple cases where I found the glandulars did make a difference. But in general, it's hard to find literature unless you go into, as I mentioned, the veterinary literature to support some of the use.
Okay. Now, a question for Dan. You mentioned vitamin A. Do you give vitamin A without checking levels?
Often, and I give generally under 10,000 IUs a day, and certainly in a menstruating female, I think that is pretty safe. But I certainly, in a menstruating female that is thinking about getting pregnant, then I think you need to think about that. But in anybody else, 10,000 IUs is very safe, and I think it's very. I think that's a level that's very therapeutic for vitamin A. Improves cellular sensitivity. So that's how much I think for this particular application you need.
So here's a question for me. Is there a way to increase or supplement DHEA without it leading to increased sex hormone production? And the way to increase DHEA without giving DHEA is with the bottom of the matrix and doing adrenal support. And you heard about that in terms of diet, lifestyle, et cetera, and sleep. However, if you're going to supplement DHEA, there's no way to do that without it theoretically increasing sex hormones. So I always, number one, document a low DHEAS level with blood test. And that tells me that it's safe to supplement. I don't say, oh, it sounds like you're depleted and you need some DHEA. Never. It's always a DHEAS supplement or DHEAS blood test. And then I always check the downstream metabolites. And I also check to make sure that the level of DHEAS after I've supplemented is within the normal range for the particular lab that I'm studying. So I make sure, and all I do when I'm checking follow-up is an estradiol and a total testosterone and a serum DHEAS. Philomena, do you want to add anything to that, or should we move on?
No, I agree. There is some literature on the autoimmune literature, and I have to say this is an autoimmune literature where they were using really high doses in patients with rheumatoid arthritis and lupus, and they weren't necessarily measuring in the initial studies. In some of the follow-up studies, they were actually measuring downstream, and they found that in those patients, as in autoimmune patients, where that may be the difference, that they weren't seeing a lot of downstream effects, but they were seeing more the DHEA levels go up. But I still agree with you. I still always check downstream effects. And I actually check one more lab than you do. I also check estrone, not just estradiol, and DHT, just to be safe.
And how do you check estrone?
And I check it in the serum.
Yeah, I have a hard time getting reliable results when I do that.
I'm always more concerned about that perimenopausal woman that has high estrone levels and is starting to lower their estradiol levels, because that tells me I need to work more on estrogen metabolism. That's one of the reasons why I do it too.
Yep. So here's a question for you. Do you ever recommend intermittent fasting to a patient with elevated cortisol?
Yes, I do. I actually really like the studies on intermittent fasting. And I think that a lot of patients at hypercortisol, if they've been that way for a long time, they will also be hyperinsulin. And I'm always checking, of course. But I use intermittent fasting quite a bit, particularly in my patients that are insulin resistant, but also in patients with high cortisol. And if they're not already doing that, or if they have blood sugar instability, you're going to have to sort of assess that and do it slowly and make sure that they can tolerate it. But in general, I'll start slow, or I'll start low and go slow, in other words. So maybe right now they're only going 8 to 10 hours without eating. So then I may go to 12 and see how they do and increase slowly. If you're looking at insulin resistance, there seems to be a little bit more information with 18 hours versus 16 hours intermittent fasting, but we have studies on 12, 16, and 18 hours.
So what is it that you would say practitioners need to look for in terms of, oh, this isn't going well, if you're doing intermittent fasting with somebody with elevated cortisol? Is there anything that they
I also look at symptoms, how patients feel. Because if they're having unstable sugar glucose levels, then they won't feel well when you have them do intermittent fasting. So if you go slow, you can monitor their symptoms and see how they feel. Most of the time, patients actually feel great. Yep. Even though sometimes in the beginning, I may be a little bit afraid to start it, or they may be a little afraid to start it.
Yeah, so let me just add to this also, Joel, that I absolutely agree with Philomena, and there's this theoretical issue about high intermittent fasting or time-restricted eating causes an increased cortisol, and so are you flaming the fires when you know somebody has elevated cortisol? And I think that's more theoretical than than at least I've seen in the research literature. And with intermittent fasting, which I call anything over 24 hours, or time-restricted eating, which I call anything under 24 hours, sometimes that gets confusing. I think that you can do that sequentially. In other words, if you can get somebody to start this time-restricted eating and going from 10 hours to 12 hours, even doing that, let's say 4 days a week. It's not like an elimination diet where you got to be off of those things for 3 or 4 weeks. And there's really, while it is a total load effect, you really have to be off of much of that to get a benefit. Intermittent fasting, time-restricted eating, I think you can get benefits on you doing that 5 days a week. You're doing that 4 days a week. You're starting at 12 hours. You're moving to 14 hours. So it's a continuum, and you can continue, as Philomena said, is you can work up, and different people can work up faster or slower. But I think, at least in my experience, everybody can generally get to some level of restricting their eating window to a smaller frame in their day, which is evolutionarily a good thing. We know.
Yeah, really good point, Stan. Thanks.
Yep, thanks.
You're welcome. You're welcome, Joel. But if you call on me, as opposed to I have to interrupt you, then you'd get these pearls quicker.
Well, there's something called a premature interruption, because you may not have realized I was about to say, Dan, what would you like to say? But anyway, be that as it may, this is now a primary question for you, Dan.
Oh, excellent.
Which is, how do you treat someone whose only abnormal thyroid lab results are elevated antibodies?
I don't know. No. So how do I treat it? So they're only antibodies. So as I said at the end of that presentation, when somebody has elevated antibodies, I am actually much more aggressive with hormone replacement therapy, much more aggressive. Now they have to be symptomatic. So if they have elevated antibodies, and nobody, I'm not in primary care, so nobody comes into me just for kind of a physical exam and without any complaints. So if I put those complaints with their concerns of symptoms with those elevated antibodies, I will, as I tried to say, I'll do all that other stuff, because elevated antibodies gum up the works in a lot of ways. They cause inflammation. They cause problems in that conversion. They change that conversion from T4 to reverse T3. So certainly doing those foundational things, almost invariably, as I said before, selenium is a given, because there's so much literature on selenium. You can't just give it for a month and think you're going to get results. You have to give it for 3 to 6 months. But I often see results of lowering thyroid antibodies because of its antioxidant abilities, and because it's so concentrated in the thyroid gland, and it seems to have a significant association. So the long-winded answer to your question is, I do all of those foundational things, and there are some additional botanicals, medications that I'll also talk about tomorrow that I would think about before giving hormone replacement therapy, which again, we'll talk about, and which I often will do in elevated antibodies.
So I know that you are not the primary care physician, but since you're in a position of leadership here at IFM and are giving our participants an education on thyroid, what would you say to a primary care physician who has a patient coming in on routine exam and has normal thyroid function, but abnormally elevated thyroid antibodies?
I would say that they got those thyroid antibodies because that they were, I don't think you just get them for no reason. You got them because you had some suspicion. And then I would certainly do, I probably would be a little bit short of hormone replacement therapy, maybe initially, but I would certainly try to encourage all of you in primary care and encourage the patient to understand that that's a progressive issue. It's like it's like hyperinsulinemia. It's like borderline elevated glucose. It's like borderline elevated blood pressure. It's if you don't do something, it's not going to go in the right direction. It's not just going to go away. So you have to think down the line of what can you do now to prevent or at worst forestall that continue dysregulation of thyroid function.
So I'm an outlier here because I order thyroid antibodies routinely on my patients as part of routine blood work, just because I want to find out if they have antibodies with or without symptoms or with or without other thyroid blood work that's abnormal. And then I do everything you say, but I'm very aggressive with gut repair and a 5-hour program because of the role that the gut has in immune health.
Thank God we agree on something.
I do this exact same thing. I check antibodies on all my patients because, I feel like if they have antibodies, they're in that sort of autoimmune spectrum. So we have to be aggressive, just as, Dan said, but I'm also really aggressive at finding what was the trigger. Was it a toxin? Was it a food sensitivity? Is there more than one? Is there a genetic predisposition? But we know that in those patients, there's also what Alessio Fasano said, right? Those 3 main things, and Dan mentioned so eloquently. There's a leaky gut, right? There is a trigger.
Absolutely, and that's part of our general functional medicine approach.
Exactly. So
anyway,
exactly. But those are the ones that I sort of jump on, and I'm really overtly aggressive with.
Yep, absolutely. So Philomena, is St. John's wort safe to take long term?
There's no studies showing long term, depending on how long are you talking about. We have some studies on 3 months. We have some studies on 6 months. Longer than 6 months, I have not seen. If some of you have, please let me know. So I haven't gone further than that. But usually when I'm using St. John's wort, I'm working the matrix. So I'm fixing all sort of the underlying dysfunctions, and I haven't had to keep someone on it for that long because we're doing a functional medicine approach.
Okay, so let's just talk about ashwagandha for our last question. How do both of you feel about using ashwagandha without testing?
Without testing for? You mean without doing a HPA axis testing?
Correct. Just like, oh, I think you need some help with your adrenals, you're stressed, have some ashwagandha.
Well, Joel, I come from the nonprofit arena, still work in the nonprofit. I still go to many places on earth, including my islands, where I'm not privy to some tests. So I use our questionnaires. And, the longer I do this, sort of the little bit more comfortable I feel in trying to figure out, is this hyper or hypo state? Given that ashwagandha, you can use them both. And over the last 5 years, we've had so many more research come out, so many more papers come out on the use of ashwagandha, for example, rhodiola also. But you're asking me about ashwagandha. I would say I feel pretty comfortable in starting patients on it. Usually I may be starting them on more than one, and I'm doing everything else that we talked about. And as far as the literature is concerned, there was one case of thyrotoxicosis, and it was thought to be due to ashwagandha, but there was no monitoring of the ashwagandha supplement. So I'm not really sure that we can say it actually causes it. That was an N of 1. But of course, whenever you look something up, it will come up. But that study was, they associated it due to ashwagandha because it was the only new supplement that patient was on.
Right. Okay. Dan, anything you want to add quickly? before we sign off?
Frankly, I agree again, and I think ashwagandha is very safe, and I use it frequently without testing the adrenals specifically.
I agree, and it does great things for midlife women as well, and that's often a go-to. And I've even formulated a supplement with a blend with some ashwagandha in it, because it does so many good things. So with that, unfortunately, time is up, and I want to thank our speakers and thank the audience for asking such wonderful questions. And these questions are all here and memorialized, and we will be addressing them with multiple Q&A from the faculty post-conference.